2,500.
500.
So Audrey has a question. Does the floating panel option achieve that floating head?
Who knows?
Something for next time.
I just muted everyone, by the way. Oh, I'll unmute you, Deb.
Yeah, so it works. All right, well, I'm going to welcome everybody to the Population Health Sciences Monday seminar. We are thrilled at the PRC to be able to welcome one of the members of our PRC steering committee is Katherine Magnuson, and she's going to be talking today about her study, Household Income and the Developing Brain, the Baby's First Year Study. This is one of the most exciting studies I've heard about since I've been on campus. I'm thrilled that we have an opportunity to hear from her about it. Dr. Magnuson is the Violet's Distinguished Professor of Social Work and is currently Director of the Institute for Research on Poverty, the National Poverty Center here on campus. She has a PhD in Human Development and Social Policy from Northwestern University and got a bachelor's degree in History and Political Sciences from Brown. Her research focuses on the well-being and development of economically disadvantaged children and their families. She examines how disparities in socioeconomic status affects children's development and how these effects may be altered by policies and programs, especially early childhood education program. She also investigates how maternal education impacts child development. And I just want to mention that all of these outcomes that she's interested in are very closely tied to health. And so her work, I think, is really highly relevant to our department and population health sciences broadly. So without taking up more of her time, I'm going to turn it over to Dr. Magnuson. I want to remind everybody to mute your microphone, and I think most of everybody's been muted already. If you do have questions through the talk, she is happy to discuss them as she goes. So please post them in the chat box, and Rosalind will make her aware so she can address those questions throughout the study. So without taking any more of her time, I'm going to turn it over to Dr. Magnuson.
Thank you for that lovely introduction, Deb. Yes, so what I'm going to share with you today is a lot of description about an ongoing research project that has really been a labor of love for myself and my collaborators. Its NIH title, so it's an NIH-funded project, is Household Income in the Developing Brain, but its public-facing title for everyone else is the Baby's First Year Study. I'm starting off with this lead slide just to give you a sense of the scope of my collaborators and the size of this project. So I'm working very closely with Kim Noble, who's a neuroscientist and a MD PhD at Teachers College at Columbia. And that's important because when we get to the specifics of the neuroscience, you'll be much relieved to know that I have an expert leading the way, and because I myself am obviously not an expert in that. We're also working with Greg Duncan and Lisa Janetian. They're both trained as economists. Nathan Fox is a developmental psychologist who works on neuroscience. Hiro Yoshikawa is also a developmental psychologist. And Dr. Sarah Halpern-Meakin, who's here at UW-Madison in the School of Human Ecology, is trained in sociology. So you can see we are a broad interdisciplinary group of PIs. And that really speaks to the scope, I think, of the study and what we're trying to do. So this study has been in the works for probably about 10 years. And it started even before that. So myself, Greg Duncan, Lisa Janetian, and Hiro Yoshikawa all had roots in studying poverty and its effects on children and families that go all the way back to the mid to late 1990s during welfare reform. And one of the things that we were all involved with at that time was doing research on how changes in public policies and support, particularly in this case, cash support in the form of transforming AFDC into TANF, was going to affect families. In doing that work, we realized or what spurred that work was a recognition that many policy decisions are made at the federal and the state level that affect the economic resources available to low-income families. And yet most of the research that is used in discussions of these policy changes is not about children and families' well-being. It's not about health. It's not about mental health even. It's really about the economic consequences of labor supply for these families, and particularly single mothers. And to us, this was an incredible disservice to understanding potential impacts on children's development. And this is exactly how we get to the public health questions that Deb was suggesting. If we take seriously the social determinants of health, then we have to be willing to think about how do changes way upstream in policies and economic conditions affect conditions in the family and children's development. So this whole project was sort of born of a deep interest in trying to answer those questions. How do policies, upstream policies, affect families that therein affect children? So what are we doing? Let me find there we go, or what's the framing? We know what I'm going to do now is talk through some of the social science and some of the neuroscience that motivates our study. One of the things that we've known for a long time in the social sciences is that children from low-income families enter school with lower academic skills than children from more affluent families, and that these differences persist over time. These are two graphs from a nationally representative study, the ECLSK, that's tracking children over time, and the quintiles of different colors, or the lines of different colors, align with different income quintiles for children's families when they enter school. So what you can see is in orange are the bottom 20% of children, and this is their tracking their reading scores over time. The purple line on the top is children from high income, the top 20% of the income distribution. You can see that they differ by about a standard deviation when they enter school for reading and for math, and those differences persist over time. Now, for someone who's interested in the foundation of educational inequality and achievement disparities, and even potentially health disparities, certainly developmental disparities, this picture is important because it suggests that what happens before kids get into school, those first 5 to 6 years of life, are what is consequential to setting them on these diverging, or at least divergent courses, right? So it really points out the importance of everything that's, Deb, can they see my mouse move? That's the one thing I didn't check.
I think I can see it, yeah.
Yeah, so it's everything that's happening in the early years before the lines even start that's consequential for what comes later. Now, as I said, social sciences have known that, and clearly what I just talked about, there we go. This is a very descriptive and not causal story about income, right? These pathways don't say that income is causing children to come into school with different levels of achievement, or even keeping them on these different paths over time. It's purely descriptive. It could be other things. Now, that said, the correlations that are well documented in the social science also have some suggestions of causation. Now, what are these studies? They're quasi-experimental studies. So there's a handful of studies by Dahl and Locklear, for example, looking at changes in tax policy. There have been studies that look at casino disbursements in the Smoky Mountains by Randall Aki and some others, Jane Costello. And there have been studies that my colleagues and I were involved in that looked at changes in welfare policy. All of them pointed to the fact that higher incomes, and higher incomes that were not dramatic in magnitude, right? So when you're thinking about a tax change of studying the EITC, you're talking about $3,000 to $4,000 a year. Maybe that is the largest benefits that families might be getting. In the casino disbursement studies, it was $5,000 a year that was being dispersed. And in the welfare reform studies, there was maybe $2,000 to $3,000 difference across families. But that handful of studies taken together suggested that if you believe that those policy shifts were exogenous to families and the findings that come out of it, they do suggest that perhaps income itself has a causal impact on children's outcomes. Now, one of the real challenges with this literature is that it focused almost entirely on school age or older children. It didn't have any direct assessments of young children. In part, that's because the studies were taking care of either existing data sets that had school-age children and were using achievement tests, but also because it's just really hard and expensive to assess very young children in a reliable and scientifically valid way. So that data collection costs are often just much higher, and people chose to study older children. There was also some not quasi-experimental, but good longitudinal work done by my colleague, Kathleen Zyle-Guest and Greg Duncan, that looked very carefully about when in the lifetime income mattered for children, right? So the story that I just talked about in terms of the quasi-experimental studies was really focusing on school age and older children. Their non-quasi-experimental, but longitudinal look with careful selection of controls and efforts to try and reduce bias, particularly selection bias, found that the timing of income that was most predictive of later life outcomes. So they were using the PSID to study differences in early childhood income or childhood income, and then much later in life when the children had grown up to be adults, looking at what their outcomes were. So they found that a $4,000 difference in annual income between natal and age 2 was the strongest predictor of increased adult earnings, time in the labor force, improved cognitive development, and some evidence also of improved health in adulthood. And that was contrasted with income at later times in childhood, right? So they found that it really was these early years in which variation and relatively modest variation in income was affecting children's later in life outcomes. Now, at the same time, moving forward, we know that even with the quasi-experimental studies, there was often some confounding. So studies maybe were affecting not just income, but also mothers' employment. In particular, that's true of the EITC, which created an incentive for mothers to work, and also true of the welfare reform studies. A little bit less true of the Smoky Mountain study, but that was also a study that was looking much at youth and teenagers rather than young children. And certainly the Zyle-Guest and Duncan work itself was not even quasi-experimental. It was just a good longitudinal research design. And so one of the fundamental questions sort of hanging over the social science literature is whether we can really move past correlation, right? Understanding that correlation is not causation, and there's other selection factors and differences between poor and non-poor families that could be driving these differences in later life outcomes rather than income itself. So myself and Greg and Lisa and Hero for a long time had been writing pieces saying, there's some good rigorous quasi-experimental evidence, but we really need to move past that and try and take a stab at establishing causation because we think that's the information that's going to be most useful for policymakers and in understanding the role of social determinants of health in predicting outcomes. At the same time that the social science literature was evolving, there also was evolution in neuroscience, right? And so neuroscientists had demonstrated very clearly that the brain is particularly elastic in early childhood. We know that there are sensitive periods for the development of capabilities and skills, and that while the ability to develop those capabilities and skills exists across the life course, that it's still the case that it's most efficient for the brain to be, quote unquote, wired in early childhood. And we also know from the social science literature, of course, that children's experience varies widely as a function of their social and economic circumstances, suggesting that these differences in social contexts and particularly economic contexts might play a really important role in affecting children's brain development itself. And I keep going to my down arrow rather than that. And indeed, in the mid to late 2000s and through the next 10 to 15 years, or at least 5 years for Kim's article, there started to be an emerging neuroscience literature in how that there were functional and, what's the word I'm looking for? Functional and differences in brain development. I'm sorry, I've just lost the word. But in terms of size, so here is Kim Noble's study that looks at how family income is associated with larger brain surface area in two particular areas. And then there's also really important work, as I'm sure most people are aware, by Seth Pollack and Bobby Wolf that was looking at gray matter itself and showing, again, in a correlational way, but showing differences in brains and brain development as a function of income itself. Again, of course, I keep going to the wrong thing. That's going to move. While there's variation from family, from person to person, those patterns are correlational, right? So the same question, and often just because of the complexity in measuring children's brains, they're also relatively small and sometimes select samples. So again, it raises the question of, we're seeing differences in brain development that are correlated with income, but do we know that income is actually something that is driving or causally responsible for differences in brain function? And just so everyone is clear, I'm going to come back and talk to what we think, talk a little bit about what we think the mediational processes are by which income would be translated into differences in brain development in child and health of brain. So I'll return to that question. But again, the driving question for us is there causation here? Can we really point to income as a causal factor in children's development? And so we spent something like 10 years putting together the Baby's First Year study to try and get an answer to this question. So we designed a randomized controlled trial in which we recruited 1,000 low-income mothers from hospital maternity wards right after giving birth. So we had survey staff. We collaborated with the Survey Research Center at the University of Michigan, whose job it was to go in every day to a hospital maternity ward, get a list of recent births, and then or mothers who had recently given birth in the rooms, and then go in and screen these women to participate in our study. This happened in 11 hospitals, 4 metro areas, New Orleans, New York, and Omaha and the Twin Cities. When mothers were enrolled in our study, they began receiving an unconditional cash gift for the first 40 months of their child's life. To be clear, the first thing that we did when we went into the hospital room, or the first thing that the field staff did when they went into the hospital room, was check to see if mothers were eligible. And I'll go over the eligibility criteria. So mothers had to have report an income, so it's self-report of an income that was under the federal poverty threshold for a family of that size when the infant would be included in the household. So an indication that with the birth of a child, they were a poor household. The child had to be in the well nursery, so not in the NICU. The nurse had to indicate that there were no extraneous or important reasons not to go in. So we wanted nurses to be be able to opt out mothers that, for example, maybe had difficulty of themselves understanding because of a developmental delay or cognitive limit. Maybe mothers who appeared to be in other sort of difficult circumstances, drugged up on pain meds, for example, might be another one. They had to speak either Spanish or English, and they had to be able to be of the age of consent. That's 18 in all sites but Omaha, in which it was 19. But those were the enrollment criteria. If mothers met those enrollment criteria, they were then asked if they would participate in a longitudinal study about their child's development and economics, or something generic like that. If mothers said they would, they were given a baseline survey, and not until after they had completed that baseline survey did we tell them that they had a chance to enter a lottery at which they'd get one of two gifts, one of two gift size. And the two gifts would be, there are $333 a month or $20 a month. That is loaded onto a debit card, and it is dispersed on the day of the child's birth. So if a mother gave birth on October 2nd, on the 2nd of every month, she would get the money loaded on of the amount that she was randomized into. The debit card was set up and activated while they were in the hospital, and then they were free to take it with them, obviously, and enjoy the cash gift for the next 40 months. We were very clear, and still are very clear in this study, that the acceptance of the gift is completely independent of the research. So mothers who do not participate in any follow-up research continue to get the gift regardless of their status in the research study. And that was very important from a coercion perspective and also sort of an ethical perspective as well. Okay, so going back to our two research questions, our first one is whether or how the unconditional cash gift supports children's development and brain functioning by the time they reach age 3. Our second question goes to family context, and it's how the unconditional cash gift supports family functioning and better enables parents to support their children's development. I will say one of the things that's been a real highlight of this project has been our commitment to open science. So all of our hypotheses for the 3 years, it's it's 3 years, I say, and then like shudder a little bit because we're dealing with COVID stuff, so we might extend it out. But all of our waves of data collection, every hypothesis that we have has been pre-registered. We also are committed to making all of the data publicly available as we can, and the baseline survey data has already been delivered to ICPSR at the University of Michigan so that other scientists can gain access to it and replicate or do their own work with our data set. So we've been really intent in being transparent and as open with our data and our science as we possibly can. Okay, so let me tell you a little bit about our theories of change. And these are shorthands for rather long lit reviews that get into the details of what we know from a scientific perspective about how income affects children and families. And so it's not the case that we think that literally handing someone $20 itself is going to magically transform their children's development. But it is the case that we think handing parents $133 a month for 40 months in a regular, reliable mechanism will be able to change some important facets of family life. So the first thing we know about higher income is that it enables parents to literally buy things their children might need. You can think about this for low-income families. This may enable them to keep heat going through the winter. It may enable them to buy more nutritious food. It might enable them to buy a bus pass so they can get to a library and enriching activities for infants and toddlers in a library series. It may enable them to get a car fixed, and you can sort of go down the list. And while this all sounds sort of mundane, one of the things that has happened in the past 20 years in the shift after PRORA welfare reform is that there are very few avenues other than employment for parents to get money to support their families, right? So there's very little cash assistance available to families. And we think that particularly at the time of the birth of a child, it is challenging to manage both the care work for the child and employment, right? And so many of the discussions and debates around paid family leave really make the point that families are at a vulnerable moment when they have young children. Childcare costs a lot. And there are high demands for their care. Obviously, infants need care. But it's very hard to combine care work with employment for many families. And even more so in a low income context in which jobs are often precarious, by which I mean there's rotating and changing shift work, there's just-in-time scheduling, and a set of labor practices that are really not conducive to building a steady employment and family routine. So we think that having money and being able to deploy it in a flexible way will literally be able to help parents buy things that we know are good for children's health and development. The other mechanism is that we know that contexts of scarcity and poverty have effects on parents' cognitive and mental well-being. So there's a long literature linking poverty to things like higher maternal depression, higher psychological distress, and a long social science literature that traces that through into interpersonal difficulties in parenting relationships and into the parent-child interaction as well. At the same time, there's an emerging cognitive science and behavioral economics literature that suggests even in the absence of stress and mental distress, that being poor takes a tremendous amount of cognitive bandwidth. Right? So the daily experiences that many middle class or upper class parents simply don't have to think about and make decisions about are consequential for low income families. So purchases at the grocery store take a lot more time and effort to consider trade-offs about price, what needs to be purchased, what doesn't need to be purchased. There's a lot of problem solving around transportation, childcare, and all of these decisions have economic consequences that require a lot of attention and cognitive bandwidth from parents. And so there's a literature that finds that all of this mental accounting, decision-making, and trade-offs, which is necessary in order to manage and raise a family with low income, reduces one's ability to put time, attention, and thought into other things such as parenting and nurturance. And so it's different than the stress pathway, but similar in that it relates to sort of internal cognitive processes rather than external processes. And we think these pathways are likely to be operating, and it may well be that it's different pathways for different families, right? One of the beauties, if you will, of providing cash, or one of the strengths of providing cash, is that it's very much an empowering and unpaternalistic approach to supporting low-income families. It suggests that they might know best how to deploy resources in order to improve their children's development. Okay, I'm going to pause and see if there are any questions about anyone want to ask me anything before I move on to tell you more about what we're doing?
I see nothing in the chat. If anyone wants to jump in, please
okay. Just keep going, but please do stop me if people have questions. Okay, so what?
Hi, it's Maureen. I have a question. I don't know if just on what you last said, which I thought was really interesting. So the cash is more empowering than. I mean, I was thinking you could in the control group, if you had given diapers or something instead.
Yeah,
maybe you could compare really
cash
that
to other types of supports. Yeah, it's a really good point. And we aren't doing that, right? So we're pitting a small amount of cash against large amount of cash. So we won't really be able to say anything about cash relative to other services, which I think is a really important point. So yeah, you're right. On the other hand, as someone that's been hanging out in this this literature about what can we do to help poor families improve their children's development, there have been a lot of approaches that are much more didactic in nature, whether it's in terms of teaching parenting directly or in, even trying to get parents into the labor market or coach them into jobs. So this is certainly more flexible, but you're right, we're not testing treatment streams against each other. And I will say what I thought you were going to ask, Maureen, and we get this a lot. This is a question we get a lot about our study is, well, certainly income matter, or not certainly income matters. If you think income matters, don't you think it'll matter even more if it's coupled with services? So perhaps either some sort of financial coaching or home visiting and not just financial coaching, but life coaching. And that also, we're clearly not testing. We really are just looking directly at the provision of cash support. Okay, if there are no more questions, I'll jump in. So what did we set up to do? We still do have ambitious data collection plans. So it's starting in May of 2018, we began our recruitment, and we set it up to be a year's worth of recruitment so that we would literally have a project that was never out of data collection. It works really well for maintaining project staff, right? They always have something to do. And when we were done with baseline recruitment, we trained and transitioned them into age 1 data collection. So the baseline recruitment, as I described, was a survey that was done in the hospital, and it was only a survey done in the hospital. Those data are now available at the university, or nearly available at the University of Michigan. They have the data and they're combing through it and about to make it available. Starting in June of 2019, we flipped into age 1 data collection. And this was a home visit into the mother's home or anywhere else they suggested would be they would be available for data collection. So it involved a survey, portions of which were computerized audio CASI for those questions that were more sensitive in nature. We did a parent-child videotape of a play interaction. That was done so that we would be able to code the quality of the interactions between the mother and the child. We were collecting hair from mothers when we could, because cortisol apparently hangs out in your hair for several months, and we'll be able to analyze chronic stress and stress physiology for mothers using a sample of their hair. We were also using Lena to collect language from the child during the mother-child play interaction. So we have that data as well. And probably the most interesting or innovative approach is that when we were planning for the age 1 data collection, we became aware of a company, I believe it's in Portugal, called Inobo, which had created a mobile EEG system. And so we trained all of our interviewers to be able to collect EEGs in people's homes. It was a challenging and fun adventure, particularly for some postdocs at Teacher's Child, because early on the product had it had some connectivity issues and some technical difficulties that they got figured out. But super exciting to be able to think that we'd be able to take this level of medical or biomedical data collection literally into children's homes and collect EEG data on them. Now, as we're all aware, starting in March of last year, or this year, I wish it was last year, starting in March, COVID happened, and that drastically changed what we were able to do, stopping in-person data collection. We were lucky in that we were able to pivot to doing the survey virtually, right? So over the phone. And that was great. On the other hand, it meant that we only have the videotape, the hair cortisol, and the EEG for a subset of our sample, and not for those in which data hadn't been collected by March. Now, we are thrilled that we still were able to keep a very high retention of their sample, which is really critically important for this type of study. These populations are highly mobile. They phone numbers, they're hard to track, and we're thrilled. I'm going to tell you a little bit more about how well we did at a later slide. We are now in the process of age 2 data collection. I think, let me see if I can get, okay, I was going to take away the red box and X just to tell you, we had planned to again do videotape interaction. A lot of our theory suggests that parent-child interactions should be more positive. We would want to measure that and measure that in ways that don't rely on maternal self-report. So those videotapes were pretty important to us, and we had planned to do another one, but can't do that because we're again, relying on virtual or telephone data collection. So we're doing a survey, but we're not in people's homes. We were also going to collect another measure of hair from the mother and from the child at this point, because we thought by 24 months, the children might have enough hair. The reason for excluding it at 12 months, at the child's 12-month data collection, is that often children don't have enough hair to collect it. We are going to get cheek swabs and do some epigenetics analysis. But we can't do that if we're not in person, and obviously direct observation of language and socio-emotional development assessments also can't be done. So we're holding on to our survey and spending a lot of time wringing our hands and occasionally pulling out our hair as we're looking to what was supposed to be our capstone data collection starting in June of 2021. I will say our hope now at this point, and we'll see if we're able to do it or not, would simply be to extend the income payments that were supposed to stop at 40 months to stop later. So maybe 46 months, maybe 52 months if we can get a full year, and push off the final data collection until a point at which we can bring children and families, because they're supposed to, we were going to bring them into neuroscience laboratories and get really in-depth assessments of the children's development. And clearly, even if we can bring children into the laboratory, the conditions of testing with social distancing and the use of masks and all of that has us very worried about what we'll be able to do. We have a great postdoc who has spent, I don't know, the last month and a half trying to learn about what, if we have to be, if we can't raise the money to continue payments, what would it look like to try and do virtual data collection, so Zoom data collection efforts, and none of us PIs are very excited or impressed with what we might be able to learn by that. That's not to say that there aren't great studies that are doing virtual data collection. I'm not bashing all virtual data collection, but I think for our very low income population and our young children, it would really be very limiting and challenging. Okay, so I'm going to tell you a little bit more about our mothers. We have 1,000 in total that we recruited. They were meant to be equally distributed across all 4 sites. We had recruitment difficulties in the Twin Cities for a variety of reasons that I won't go into, but it had to do with the specific hospitals we were recruiting from. Were not a good match for our population. And they also required a different process for approaching mothers, which ended up being a barrier to recruitment. And so we distributed other populations across the other 3 sites. About half of our mothers report being Black or African American. By far, the largest number, or percentage-wise, the largest percent is in New Orleans, which is a poor African American community where we recruited from in that city. And about 40% of our mothers report being Hispanic or Latino. Now, there is some overlap between those 2 groups. In New York, we sampled out of the Bronx area, which is highly populated by Dominicans, which often identify as both Black and Hispanic. a great relief to us was to be able to look at our baseline survey data and find out that, in fact, our randomization process had worked. You know, some people look at 1,000 and they think, oh, that's a big sample. Some of us look at 1,000 and think that's a small sample, and then we worry that, you know, maybe we won't really get balance on our baseline characteristics, but we did. You can see that, and this also provides an opportunity to talk about some other characteristics of the families at baseline or the mothers at baseline. You can see because we were we were selecting on healthy babies for the most part, they're full term. They were about 7 pounds. Moms were on average 26 to 27 years old. They on average had less than a high school education, so less than 12 years. We already talked about race and ethnicity. They did not at the time, so it's always a little dicey to get a measure of maternal depression at the time of birth for lots of reasons, but we didn't see elevated depression at that time. We, on average, the number of children that these mothers had was about 2.5, and we saw a fairly even distribution. About 1/3% of the moms were new moms. This was their first child. About 1/3, this was their second, and about 1/3, this was either their third or higher order birth. About 40% of the moms have the bio father in their household. That doesn't mean that they are their own household unit. About 1/3 of the moms were also living with their parents or other relatives. And on average, as you would expect, and as was necessary to get into the study, these are low-income moms. So the average household income was somewhere between around 20,000, 22,000. So low-income moms. We talked about hair cortisol. So that's an exciting feature, and there's some good evidence to suggest, or some prior evidence to suggest, that hair cortisol might well predict neurodevelopmental differences in children. So we were really excited to see what we learned from that. And again, more about our EEG. And the picture of the child with the red cap on is what the Inobo looks like. And so my neuroscientist, Kim Noble, would tell you, my neuroscientist colleague would tell you, that the signals are decomposed, the EEG signals are decomposed into oscillations that occur in different frequency bands, and that these can be separated. And prior research, some of which has been done in her lab, suggests that children that are at risk for learning and attention disorders tend to exhibit excess low frequency oscillation, and then a deficit of the high frequency oscillations. And we're currently in the throes of analyzing these data from our H1 data collection. And I can tell you, I have learned how not straightforward it is to analyze EEG data, especially as you're pulling apart bands, and there's lots of details to how many epochs you have and how it's processed. But it is exciting to have used this method, which is, you know, really has the potential, I think, to enable people to think about embedding things like EEG data into population survey. Very exciting. The other thing, we spent a lot of time before, I think this is important for other researchers to hear, thinking about whether, you know, behind the discussions or in advance of the discussions about whether how many epochs we need and how to process the data, were lots of discussions about whether we could get low-income families, mothers in particular, to allow us to come into their home and put these caps on their heads and collect EEG data, knowing that we weren't in fact going to then share it back directly with them because it's not interpretable in a way that's going to provide them any individual feedback. We did focus groups to ask moms how best to present it and what questions they would have, what they would want to hear more about. We also put together a videotape that explained it, and we showed that to the focus groups and got their feedback on what to do differently, and made revisions to the script for the videotape, or, you know, whatever. It was a tablet, it wasn't an actual videotape, you know, and it was maybe 3 minutes long, so it wasn't long, but it really walked through what we were doing and why we were doing it. And I think one of the things that was most important in getting the consent and willingness of families to try this was to explain what we would get from EEG data that we couldn't get in other ways. And so trying to explain that, and this worked very well, because it's true, with a 12-month-old, you can't understand how they're doing simply by asking them questions or even by just listening to their language, right? I mean, you can learn some things, but it's obvious there's a lot going on in development that can't be quantified simply by looking at a 12-month-old or asking a mom questions about a 12-month-old. And that actually resonated very well with many of the moms who sort of got it like, oh, okay, you can understand what's happening in my child's brain, even though they can't articulate it or I can't tell you what's going on. So I think it was really important to be successful that we had the videotape, that we got feedback on it, and that we really listened to the community about how best to explain the EEG data collection to them. So we were able to get babies capped 84% of the time, and that ended up with 69, so 70% of the in-person visits having usable data. Reasons why they didn't have usable data, you could put the cap on and the baby would rip it off. That does happen. I'm sure many of you know that. And you could also have a baby be asleep or a mom simply say no. So it wasn't the case that we could get it from everyone. Another really important and exciting part about this study is that it's mixed methods. So Sarah Halpern-Meakin is leading an embedded qualitative study that's happening in 2 of the sites. It's in the Twin Cities and in New Orleans. We have at times kicked ourselves for not also doing it in New York and Nebraska. It'd be nice to have full representation. The logistics of it just, and the cost of that just got to be a bit too much. From the transcripts, so it's a total of 80 moms that she's talking to, 50 of which are in New Orleans. And again, we were going to have equal representation between the Twin Cities and New Orleans. But at the end of the day, when we had lower recruitment in the Twin Cities, that didn't seem to make sense. So we shifted to doing more interviews in New Orleans. When our interviewers, and down in New Orleans, we are in both sites, we're partnering with local partners to do the interviews. And so down in New Orleans, it's the Louisiana Public Health Institute, who just has 2 really great researchers who are doing these interviews. What we've heard initially from moms when they were interviewed, and they were interviewed for the first time in the qualitative study at starting at about 9 months, and we have 4 waves of data collection that we're doing, which is great because it provides an opportunity for us to look at the survey data and think about what other questions, what do we want to learn more about in the qualitative interviews and ask more questions about, and vice versa. What are we hearing in the qualitative interviews that we want to build into ask questions about in the survey data? But certainly stories early on about moms who received the high cash was stories about appreciation and how much help it is, how having that cash was helpful. So talking about using it to buy food when food stamps run out, and talking about using it in the hospital to go get a car seat and get a ride home through a lift, because you do in fact need money to get home from the hospital if you don't have your own car, and you can't ride a bus. So I said most of this actually about us pivoting in light of COVID-19, and I'll say a few more things about that. While one of the questions we now get frequently from people listening to presentations is the extent to which we think COVID-19 has jeopardized our ability to answer the study's core research questions. And our typical answer goes something like this. The fact that we to telephone interviews at age 1 is not a terrible thing. None of us were happy about it. We had all these cool other mechanisms of data collection that were really important, but this is a 3-year treatment. We don't necessarily expect strong impacts after 1 year on health and on our measures of health and development, more so on our measures of family process, because that's the proximal thing that we think income, right? In our logic model, that's what we think income's first going to change. And a lot of those measures are on our survey. So it's issues around mom's mental health, issues around economic hardship, relationship quality, that we're still collecting data on, which is great. We also know that because we have the treatment group and the control group and the beautiful RCT setup, we know that both groups are experiencing COVID at the same time. And the differences in the rollout of COVID, if you will, or the experience of COVID differ across the sites. So it's even more important that we're randomized within site. Now, clearly it changes the economic and social and health context in which we thought we were studying. And it's interesting to think about because prior to COVID, the economy was actually in very good shape. There was incredibly low employment, or unemployment rates, rather high employment. And that was, to be honest, a somewhat unusual economic context to be studying poverty. Now we know that unemployment is much more widespread. There's a lot more economic hardship, uncertainty, and frankly, economic, for lack of a better word, chaos in people's lives. And I say chaos because it's both the case that people are facing unemployment, but also the case that there were government transfers. So many people got money from the government in the stimulus, and unemployment for when it was being federally provided prior to July, from March to July, was actually quite generous. So we think that at the end of the day, we'll be able to still say something about the causal impact of poverty reduction. That beauty of the randomized control trial is really helpful to us in these circumstances. On the other hand, now we'll be talking about the value of poverty reduction in a time of pandemic, complicated unemployment, complicated public benefits, all of the above. So it certainly does change the context. We are also, in light of the social unrest around police brutality and racism, and because of the pandemic, added topics into our surveys to collect information in that. And that became really evident to us because in particular, for example, our mothers who were living in the Twin Cities, they themselves were under lockdown, not necessarily because of the pandemic, but because of the racial unrest and civil unrest. And so in some of the qualitative interviews, you hear stories of moms literally who lived around the corner from the dollar store at which George Floyd had been in. So, and that had been the store at which they had been purchasing, diapers or something. So there's a lot going on that was unanticipated, but we think at the end of the day, we'll still be able to say something about poverty reduction. And that, of course, is only if we're able to figure out our capstone data collection, which looms large. Just to toot our own horn, we get really excited to talk about how successful our age 1 data collection was. So we actually got 94% of the 1,000 mothers was our retention rate, which is in this type of population really extraordinary. In particular, given that we had to stop in-person visits and only do it by phone. And you can see for those that we didn't get, there are some hard refusals, a bunch of people we never were able to actually catch up with, we just weren't able to find. But those are the other reasons for why we were not able to interview. And the mother-child separations, we decided that we wouldn't do the interview with them simply because so many of the questions are about the children and caring for the children that it wouldn't have made sense. We will go back and revisit them at age 2 and see if they are still separated from their child, and if they're not, they would then be included. So as I foreshadowed, we have lower levels of data for our really cool, novel, innovative features of our data collection. Due to COVID, hair cortisol is due to moms taking steroids or literally not having the hair or refusing. And EEG, I already talked about issues with capping. I'm going to skip over this. The other thing, we have 2 other cool aspects of our data collection, is we ask moms if we can follow their use of their money on their debit card. And 95% of moms said that we could. So we actually can track in with some specificity when and where the mothers are spending their money. We don't know what they are spending it on. So we have what's called point of service information. The good news is when you build this kind of intervention or this kind of program, you don't necessarily, you have to think about a lot of things. We worked really hard to find a debit card company that could provide consumer support in both English and Spanish, would allow moms to replace the card, and then also wouldn't charge high fees for any sort of, card replacement or something like that. And we're able to see really high use, not surprisingly. Low-income moms are using the money that's provided on the card. And so we can see that there are only 7 people who have never used the card. That may sound like a lot, but that's actually pretty impressive when you think of things like the EITC or other programs that are trying to support families by giving them more income, and that have much lower take up than ours did. We also have a debit card line that we ourselves staff with project staff. And a really good thing to know is that we do get calls. We get 15 calls a week. Someone's lost their PIN, lost their card, don't understand why it won't work. And where our staff are able to go look in the debit card information system and answer questions or remind them how to reset their PIN or something like that. So we know that moms are actively using this money. We're able to look at how soon they use their money. And again, maybe not surprising for people that are familiar with low income families and communities. What we see is that particularly moms who are getting the high cash gift, tend to use their $333 a month almost within a day or 2 of having the money loaded. So it turns out they're not, particularly those with the large amounts of cash, the 333, they're not saving that money. We see a little bit more saving behavior among those that are only getting the $20. The qualitative studies will be like, I can't get anything with $20, but if I wait another month, then I can get a large pack of diapers. So we also know how moms are spending it. Again, point of service, not what they're spending it on. And the 2 largest groups are ATM, so they're able to withdraw it as cash, enabling them to spend it on anything they want. But then also large shopping stores. So these are Targets, Walmarts, that sort of thing. And in the qualitative data, you even see moms being pleased that they can shop online because you need a credit card to purchase things online. And no surprise, ordering diapers online is cheaper than going to a corner store and purchasing them there with cash. The other thing that we'd like to point out is we see very few purchases at tobacco or liquor stores, so it doesn't look like the bulk of the money is being spent exclusively on that. Although I like to remind people that certainly in 3 of the sites, you can purchase alcohol in a large chain store. So it's not proof, it's not negative proof, if you will. I'm realizing we're coming close to time. I'll just end with our dilemmas for our age 3 data collection plans by way of saying that I know many of us who have ongoing research projects are in these types of conundrums. We're currently planning for, as I said, in person and virtual, although It's looking less and less like the virtual would be the way to go. We're considering contact drop-off and pickup of tablets, trying to use Wi-Fi hotspots, all of that great stuff. But by far, our most desired outcome would be extending payments to the by some number of months, some magic number of months that'll get us to a point where it would be safe to have in-person data collection. This is an expensive, I'm going to see where I have this. This is an expensive project. We'd also like to follow people through age 6, by the way. Okay, I'm just going to stop here. It's an expensive project. So we have built a coalition of what we call the willing. We have a lot of private foundations. We have a large RO1. So we are already funded to the tune of $17 million and are now looking to raise 2 more. So we'll see if we're able to do it. We have some hope that we'll at least be able to postpone data collection a few months. But it's a large undertaking to sort of move a big ship. So we're hoping to be able to do it. I realize I'm right at time, so I'm going to stop and see if anyone has at least one question or one thing they want to hear more about. Thanks, Deb.
We have a few questions in the chat.
I was going to, I can see the questions too, and I was going to start at the bottom if that's okay.
Sure.
And this one's from Kelly Johnson, and she says, I wonder about selection bias from the nurses who had the authority to screen out candidates before recruitment.
Yeah.
The criteria seems quite subjective and maybe opens some bias towards healthier seeming moms.
Yes, I think that's an important thing. It's a thing we worried about quite a bit. At the end of the day, we felt like we were turning to hospitals to be partners with us, and that was really something that they felt was very, very important. I'd have to check. I think we have a little bit of information, but not much on what those circumstances were. The nurses would tell us that it really had to do with the mother's health rather than other things. And there were times also because they knew that we really were looking for, that they knew that we were looking for Spanish and English speaking. They would also help us by saying, okay, no, they're clearly Hmong and not speaking English or speaking another language that wasn't. So, but agreed, we worried about that a lot too. And at the end of the day, it just was really important for the hospitals we were working with to have that level of decision making.
Great. And we are on the hour. There are a couple of other questions. So if people can hang around for 5 minutes, we can address them. But I just want to, again, Katherine, thank you so much for this presentation. I wish you well in navigating this complex landscape, but this is a really important study. And I do hope you're able to raise additional funding so you can extend data collection.
Send all millionaires our way, Deb. Yeah, I'm laughing too. Thanks everyone who took the time to listen. I really appreciate it. And be well. Hey, Deb.
Yeah.
Do you want to, let me stop this and see if I can find the text. I have another thing that I'm supposed to get to. So I was wondering if I could, I'm sharing. How do I stop sharing? Okay. If I could collect the comments and then I can respond.
Yeah, I'm going to do a screenshot. That's my new tool here, and I'll send them to you.
Okay, awesome. Then I'll respond to people.
Thank you again. Bye, everybody.
Bye.